Hello and welcome back. So in this part of the lecture, we will discuss different treatment options for women who have endometrial hyperplasia with atypia and endometrial hyperplasia without atypia. So in the previous lecture, we said that there are two types of endometrial hyperplasia. One is without having these atypical cells, which is without atypia, which is less serious compared to if a woman has endometrial hyperplasia with atypia. Okay, so but still endometrial hyperplasia, even without atypia, there are some chances that it can, in the long term, over a period of many years, it can change into endometrial cancer. So the risk of endometrial hyperplasia without atypia progressing to endometrial cancer is less than 5% over 20 years. Please always remember that all types of cancers, they progress slowly, like no cancers develop in 1 week or 1 day. Okay, so and most of them, they take, especially carcinomas. Okay, so they take a longer time compared to sarcomas. Majority of cases will regress spontaneously during follow-up. So if there is endometrial hyperplasia without atypia, if we start treatment, majority of them, they respond, okay, and they regress. And especially if there are reversible risk factors, like if a woman has high BMI, or if she is, say, for example, on any medication, hormone replacement therapy, for example, these or even if her sugar levels are high, like if she has pre-diabetes. So if we improve these conditions, then automatically the chances of her regression, they are improved. Okay. So what is the treatment? See, we said that endometrial hyperplasia is one of the risk factors is actually it's estrogen, right? So if we give her progesterone, which can be in different forms, that's the treatment. So the ideal treatment for women with endometrial hyperplasia without atypia, that's progesterone. Now, what are the different uh, delivery methods? The ideal one, if there is no contraindication, that's the levonorgestrel intrauterine device or intrauterine system, which by the brand name is Mirena. Okay. So that's if there are no contraindications. We have a separate lecture where we'll be discuss about what are the indications of Mirena, what are the contraindications. So just one of the indications for levonorgestrel intrauterine system is hyperplasia without atypia. Okay, so but just to let you know, so the cavity should not be too big. It should be regular, which means there should not be big fibroids, for example. Here there should not be congenital anomalies of the uterus, like it should not be a unicornuate or a bicornuate or a septate uterus. Like the shape should be normal, the size should not be too big, there should not be problems with the cavity. Okay, so these are some of the things we have to consider, but there is a list of indications and contraindications for Mirena, which will we cover in separate lecture. So basically, why Mirena? Because levonorgestrel intrauterine system, actually it causes regression of the endometrium, right? It causes thinning of the endometrium. But whenever there is thinning, so there is always, as a side effect, it can cause irregular menstrual bleeding, especially in the first 3 months, 3 to 6 months, and it can cause absence of periods, amenorrhea, right, in some women, but it takes almost 1 year. So, and some women do not like not to have periods, so that's taken as a side effect. Okay. So if a woman says, no, I do not want to have this thing placed inside the uterus, then what is the other option? They can have oral progestogens. They should be continuous. Okay. So continuous oral progestogens should be used for women who decline levonorgestrel intrauterine system, or if there is any contraindication. Endometrial surveillance should be arranged at a minimum of 6 monthly intervals. What do we mean by endometrial surveillance? It means that take repeated biopsies. Okay. So take repeated biopsies, endometrial biopsy at 6 monthly interval if there is endometrial hyperplasia without atypia. Okay. So it is also a contraceptive. Okay. So if there is atypia, what is the treatment? So in a previous slide, we said that if there is endometrial hyperplasia with atypia, there are 43% chances that the patient has endometrial cancer in some other part of the uterus, right? So because we sample do not all of the endometrium, right? It's usually only 10%. So there are high chances that the patient already has cancer. So women with atypical hyperplasia should undergo a total hysterectomy. Total hysterectomy means remove the whole of the uterus and also remove the cervix. Okay, subtotal means leave the cervix but remove the uterus. So a total hysterectomy because of the risk of underlying malignancy or progression to cancer. Now, postmenopausal women with atypical hyperplasia, it's actually easy, right? Because postmenopausal women, they have usually completed their fertility, or of course, they cannot naturally, they cannot get pregnant. So, postmenopausal women with atypical hyperplasia should be offered bilateral salpingo-oophorectomy together with total hysterectomy, right? So, bilateral salpingo-oophorectomy means salpingo is the term used for fallopian tubes. So, and oophorectomy is like salpingo-oophorectomy means remove fallopian tubes and the ovaries. Okay, so because ovaries mostly have done their job, right? Although ovaries release a little bit of testosterone, but their main role is to produce estrogen, right? And involved with ovulation, and they are important for fertility. So in postmenopausal women, the decision is easy: just remove BSO, remove the fallopian tubes and the ovaries. Now, the problem is if it's a younger woman who still hasn't started her family, or she hasn't completed her family. Now, that's the problem. And if she has endometrial hyperplasia with atypia, okay? So, women wishing to retain their fertility should be counseled about the risk of underlying malignancy and subsequent progression to endometrial cancer. So, they should be clearly told about this thing, right? There are high chances that there is 43% chances that maybe there is already endometrial cancer. So, if they still understand all of the risk factors, all the a background, but they want to retain their fertility, then still they can have Mirena or oral progestogens, depending on whichever they choose. And then instead of 6 monthly, we have to do more frequent endometrial biopsy, which is 3 monthly. Okay. So now, what are the indications for hysterectomy related to endometrial hyperplasia? Like, when should we remove a uterus? The list is very long, but we are talking only related to endometrial hyperplasia. Okay. First is, of course, the woman should not want to preserve her fertility, right? See, for example, progression to atypical hyperplasia occurs during follow-up. So initially the patient had hyperplasia without atypia, but on repeat endometrial biopsies, which we were initially doing 6 monthly, then if we notice that, oh, now she has endometrial hyperplasia with atypia on histopathology, right? Or if there is no histological regression of hyperplasia, like still the same, it's not going back despite having treatment for 12 months, or if there is relapse of endometrial hyperplasia after completing progestogen treatment, or if there is persistence of bleeding symptoms. Like, okay, we initially thought that it's endometrial hyperplasia even without atypia, right? We started some treatment, but she's not responding. That means there is something sinister, right? Okay. So in that case, we may need to biopsy again, or like if there is high level of suspicion and she has completed her fertility, yes, then remove the uterus. The woman declines to undergo endometrial surveillance or comply with medical treatment. Like, we think that she won't come back for repeat follow-ups, right? So, and then what are the different methods where the uterus can be removed? It can be open. Open means it can be by a big cut on the abdomen, or it can be a laparoscopic hysterectomy. Now, and even in laparoscopic means that, like, still at laparoscopic hysterectomy, so usually this is the position which is adopted. That's called, yeah, there is one position which is called lithotomy, right? In which hemorrhoid repair is usually performed in surgery, or in normal delivery, vaginal delivery is carried out in lithotomy position. But Lloyd Davies is slightly, there is a difference from lithotomy position. It's less angled. Okay, so why I'm showing you this picture, because even if it is performed laparoscopically, one of the assistants has to sit here, right, towards the here between the legs of the patient. And why it is important, because they have to manipulate the uterus. Like, if this main surgeon tells that, okay, introvert the uterus or retrovert the uterus, they have to move it backwards and forwards. And then the sample, the uterus is actually removed through vagina. Okay, so that's an important position to assess uh, a total laparoscopic hysterectomy. Okay, so then we have a fifth slide related to endometrial cancer. There is again a FIGO staging. I'm not going to go through all of this, but it's better if you just read it on your own self. So there are 4 stages. In stage 1, it is mainly limited to the uterus, right? And then it has 1A and 1B, which means whether less than 50% of the myometrium is involved or more than 50% of the myometrium is involved. Then in stage 2, the cervix it's involved. Then stage 3, it's in the pelvis. Like it can involve now there are stage 3, A, B, and C. Okay, but still it's within the like invasion of the adnexa or uterine serosa in 3A, B, invasion of parametrium, 3C is invasion of pelvic or para-aortic lymph nodes. Stage 4 is distant organ involvement, or even if the rectum is involved. Okay, so that's why if any pelvic cancer, if we are suspecting cancer, we always have to perform a rectal examination, because if it has already involved rectum, that's already stage 4. Okay, now the stage is one thing and grade is another thing. Grade is how do the cell look like compared to normal cells. Grade 3 is the worst, grade 2 is kind of moderately differentiated, and grade 1 is like they look closer to normal cells. Okay, so always the prognosis of the patient, it depends on the grade and the stage. Okay, this may look different, like the staging 5-year survival rate for all cancers, the survival rates are given as 5 years. Okay, compared to ovarian cancer, 5-year survival rates for endometrial cancer, they are better. And they may be slightly different in different books, but this is, you do not need to memorize it. Okay. And that's it basically. I mainly took it from Management of Endometrial Hyperplasia, which are the RCOG guidelines, and Gynae White and Teachers, the 20th edition. If you have any questions, just drop me a message or leave